Knee joint pain can be caused by various problems. Most of them will be inflammation-based, such as arthritis, trauma, gout, rheumatoid arthritis, or regular osteoarthritis.
Arthritis is a term that literally means joint pain. The most common form of arthritis is degenerative arthritis or osteoarthritis, which is the natural process of aging and wear and tear in the joint. The second most common cause would be rheumatoid arthritis, which is a disease that actually attacks the joint and destroys it. Traumatic arthritis develops in people who've had trauma to their joints in the past that then hastens the wear and tear and later in life becomes painful.
The diagnosis of knee joint pain depends on taking a good history, finding out when a patient's hurting and what causes their pain to be exacerbated. It also depends on a good physical exam. Many times patients will come in complaining of knee pain and it's actually coming from their hip and they didn't realize it, or it's coming from their lower back where they'll have a pinched nerve or a sciatica. Most of the time we will take some type of radiographic studies, usually plain x-rays when the patient's standing, to see what happens with their leg when they're standing. Sometimes we'll have an MRI scan done, although not that often do we need to have an MRI scan done with someone who has a routine knee pain presentation who did not have a specific injury. Many times when someone's had an injury, we would want to do an MRI scan potentially, but not in the average patient who comes in to see us with knee pain secondary to arthritis.
Knee arthritis is being treated by several ways. Typically we divide them into operative and non-operative. The non-operative arm of this is anti-inflammatory medications, weight loss, exercises, avoiding of activities that hurt, and the various medications such as over-the-counter anti-inflammatory medications as well as prescribed medications. Once that fails, including physical therapy or self-directed physical therapy, we discuss injections, and injections can be boiled down to cortisone injections or gel injections.
Depending on the extent of the arthritis that a person has in their knee, there are many different options to start with. The last option is knee replacement surgery, but usually we make sure to exhaust every other potential option. Some physical therapy and work on exercises is important in someone who has some early arthritis. Many times we will use anti-inflammatory, anti-arthritic medications. Sometimes we will use cortisone injections or other injections of visco supplementation. Ultimately, if a patient continues or presents with significant severe arthritis, it may lead to the recommendation for knee replacement surgery.
Knee replacement surgery is fairly uniform in that we replace all the joint surfaces to try to prevent pain from coming back even after knee replacement. There is a partial knee replacement that replaces just a part of the knee, but that relies heavily on the rest of the knee being pristine, meaning there's no other damage, no arthritis, and no pain in the rest of your knee except for a specific portion of the knee. Other than that, there's different approaches to do the operation, but you will always come out with a scar in the front of the knee and a well-functioning knee replacement.
The advantage of partial knee replacements is it's a smaller surgery, so it's going to hurt less. You're going to get better relatively easier, and your knee will seem a little bit more like a natural knee. The longevity of partial knee replacements is not quite as good as the longevity of a total knee replacement. We would expect a total knee replacement under normal use to last you 20 years or longer. For partial knee replacements, its lifespan is probably about 10 years average.
Knee replacement surgery, basically for the majority of patients that we do this on, involves replacing the entire joint. By the time they come to us and are bad enough to consider this type of major surgery, have arthritis throughout their knee, not just limited to one out of the three components of the knee. They have an angular deformity, either their lower leg will bend in or bend out, and this is something that can only really be addressed with a complete knee replacement.
Knee replacement surgery involves removing all articular cartilage damage that you've had from over the years of use. Articular cartilage is the covering of the knee surfaces, and this typically is the area that deteriorates with osteoarthritis.
Knee replacement surgery means making a reasonably long incision in the front of the leg, approximately this long, to allow us to first work on the alignment. Most patients have either a knock-knee deformity or a bow-legged deformity, which needs to be corrected at the time of surgery. So the first thing we do is work on the ligaments to help correct the overall alignment. Then we remove the damaged bone and cartilage and replace it with a metal and plastic knee in most cases. This involves some final measurements and really a custom fit based on what a patient's anatomy is. So the procedure itself takes about an hour and a half. The whole recovery takes somewhere from 2 to 3 months.
The only benefit for knee replacement that you should consider is pain control. This is not an operation for range of motion. As a matter of fact, we typically will say that range of motion stays the same before and after surgery, although we do try our best to make it more. It is not an operation to make you stronger. Physical therapy and exercise needs to be done for that. This is strictly for pain control and only after non-operative management fails.
The risk of knee replacement surgery, short-term and long-term, are a little different. Short-term, the surgery itself, like any other big operation, there's always a risk of a problem with their heart, with a lung problem, with a blood clot that may go to their lungs, with a possible infection. Like any big operation, there's about a 1% chance of a major complication such as that. Longer term, the risks of a knee replacement surgery is stiffness and the possibility of the replacement wearing out. So although 95% of people do very well long term, approximately 5% of people in their lifetime will have an issue with the knee wearing out or with them not being as happy with their knee replacement as they were early on afterwards.
Some of the deficiencies that total knees have, everybody gets numb on the outer half of their knee. That's going to be noticeable right after surgery. A year from now, you'll still be numb, but you probably won't notice it. Since they're made of metal and plastic, they sometimes click, and that's not a problem unless there's pain with the click. Artificial knees are not as stable as natural knees, as they're designed to sacrifice usually your anterior and very often your posterior cruciate ligaments. So they're not always as stable side to side or front to back as a natural knee, which makes them not good for running and jumping. Not everyone can kneel on their artificial knee. Most people walk and usually walk better than they did with their arthritic knee. Most people can go up and down stairs. Most people cannot climb ladders. Not everyone can hike in the woods with an artificial knee, but you should experience significant improvement in your pain, and generally you're going to be better than your worn-out knee, but not as good as your natural knee was.
There is really no other limitations to knee replacement. We don't worry about them dislocating. We don't want you to be falling and breaking around knee replacement, but that's not something that is a limitation, just one of the precautions.